study MRCOG. In this YouTube series, we'll be discussing about the antibiotics, NSAIDs, antihypertensives, and anticoagulants topics from the module Pharmacology for Part 1 MRCOG examination. So the best way to predict your future is to create it yourself. So briefly about what are the topics to be covered for Part 1 MRCOG examination, we have to look at the classification of the drugs, of pharmacokinetics, placental transfer of drugs, as well as pharmacodynamics, mechanism of action, indication of each drug, where it should be used, side effects, the teratogenicity, which is very important, and also contraindications. Which are the group of drug which we need to cover up for the MRCOG Part 1 examinations? Antibiotic groups, antivirals, antifungals, antimalarials, anti-epileptics, anti-thyroid, anti-androgen drugs, antiemetics, antihistamines, anti-cancer drugs, such as chemotherapeutic drugs, urogynecological drugs, drugs which are used for gynecology, abnormal uterine bleeding, hormone replacement therapy, contraception, which is very important, analgesics, anesthetics, NSAIDs, as well as vitamins, and also the drugs which are used for the induction of labor, the management of the PPH and prevention of PPH, which are the uterotoxics as well as the oxytoxics. So in each question, read the question very carefully. Sometimes the question will have a buzzword, but there can be a direct question as well. Also, choose the best option from the given options available, because it is a single best answer. You might find more than one answer correct, but you have to choose a single best answer. So now coming to about the proper topics. So start with the antibiotics. So antibiotics can be classified into different groups based upon the mechanism of action, as well as whether it is a broad spectrum or narrow spectrum. And so based upon the mechanism of action, the antibiotics which acts by inhibiting the cell wall synthesis are mainly the whole group of the beta-lactam antibiotics, which is a penicillin group of antibiotics, the cephalosporins, carbapenems, as well as the glycopeptides. The beta-lactam antibiotics can include ampicillin, amoxicillin, the penicillin G, benzyl penicillin, benzathine penicillin, as well as all those other penicillin and clavulanic acid combination. Can all those whole group of broad spectrum antibiotics, mechanism of action is by inhibition of cell wall synthesis. Cephalosporins, the next generation, next group of antibiotic, which have got 5 generation. And the first generation cephalosporin, which is a cephalosporin, is used for the surgical prophylaxis for cesarean section. And because it is closely linked with the penicillin group of drugs, they have got cross reactivity with the penicillin group of drugs. And also the next group is carbapenem, which include the meropenem, imipenem, which are all the higher end antibiotics, and the glycopeptides, vancomycin, which is a drug of choice for MRSA infections. And also if there is any acid allergic reaction to penicillin, sometimes we have to choose vancomycin. The next group of drug is a protein synthesis inhibitors, which can either be inhibiting the 30S ribosomal subunit of the protein synthesis or the 50S ribosomal subunit of protein synthesis. These are very important. It has been asked repeatedly in previous recalls. So which are the antibiotics which act by inhibiting the 30S ribosomal subunit of protein synthesis? They are the aminoglycosides like the gentamicin, streptomycin, and the tetracycline group of drugs, so which includes doxycycline. Coming to about the aminoglycosides, gentamicin, the side effect is mainly ototoxicity, and streptomycin can have a side effect of nephrotoxicity also. Tetracyclines are a group of drugs which are to be avoided during pregnancy because it is category X drug in pregnancy because of the irreversible discoloration, the brownish discoloration of the teeth, as well as damage to the bone and cartilage. So they are acting against the 30S ribosomal subunit of the protein synthesis, that is aminoglycosides and tetracyclines. Now, what are the antibiotics which act against the 50S ribosomal subunit of the protein synthesis? They are the macrolides, which are mainly including the azithromycin, erythromycin, which can be used in pregnancy safely, and the other group of drug which are the lincosamide antibiotics, which includes mainly clindamycin, that can also be used in pregnancy. The another group of drug is a chloramphenicol, but it has to be avoided during pregnancy because of the teratogenicity risk of gray baby syndrome. Then there are antibiotics which acts or inhibit the DNA or the RNA synthesis, which are called as the nucleic acid synthesis inhibitors, which acts by inhibiting DNA gyrase enzyme, specifically fluoroquinol, that again ofloxacin, ciprofloxacin, and antibiotics which are to be avoided during pregnancy because of the damage to the bone cartilage. And another group of drug which inhibits the nucleic acid synthesis or the DNA synthesis inhibitor is a metronidazole. Very important, especially in gynecology and in sepsis infection, because it is one antibiotic which has got a nitrosyl radical and it acts against the anaerobic organisms, so bacteria as well as the protozoa. Then there are a group of drugs which acts against the folic acid synthesis. They are sulfonamides as well as trimethoprim. Of this, the sulfonamide group of antibiotics and trimethoprim are to be avoided during the first trimester of pregnancy. Specifically, sulfonamides have, when there is an intake of sulfonamides, we have to give high dose of folic acid, 5 milligrams once daily, has to be given during pregnancy. But it has to be avoided during the first trimester specifically. Now, the sulfonamides again has to be avoided, its intake has to be avoided during the third trimester because of the risk of crossing through the blood-brain barrier of the fetus and resulting in kernicterus. Another drug which can cause kernicterus because of the intake in the third trimester is phenytoin. And there are other anti-TB drugs as well. So this is one slide which helps you for a final revision, a quick revision where you can see aminoglycosides against protein synthesis, cephalosporin cell wall synthesis, tetracyclines protein synthesis, penicillin cell wall synthesis, sulfonamides folate synthesis, fluoroquinolones DNA synthesis, macrolides protein synthesis, carbapenem cell wall synthesis, lingozamides protein synthesis, and glycopeptide cell wall synthesis. To have a quick memory about the mnemonic can be used like MALT. Basically, all are against the protein synthesis, and which includes macrolides, aminoglycosides, lingozamides, and tetracyclines. And of which the macrolides and lingozamides are against a particular ribosomal subunit, and aminoglycosides and tetracyclines the other particular group. So as I've mentioned, there are broad spectrum as well as narrow spectrum antibiotics. That is nothing but if it is effective against only one particular gram-positive or gram-negative microorganism, that is a very narrow spectrum, includes the penicillin G, which is only active against the gram-positive organisms, and the aminoglycosides against the gram-negative bacteria. While the broad spectrum, they cover both gram-positive, gram-negative organisms like ampicillin, amoxicillin, cephalosporins. So metronidazole we discussed, it acts, have got inhibition of DNA synthesis and cause DNA damage by oxidation. Nitrofurantoin is another drug which is commonly used for the management of UTI in pregnancy, even for prevention as well as suppression dose. But to be remembered, it has to be avoided during the third trimester of pregnancy because of the side effect it can cause on the baby, that is acute hemolytic disease of the newborn. So it basically acts by reducing the flavoprotein nitrofurantoin reductase to unstable metabolites, and this disrupts the DNA, the ribosomal RNA and DNA and other intracellular components. Some sulfonamides we already discussed, antifolate antibiotic, and to be avoided during third trimester because of risk of kernicterus. Clindamycin, it is a lingosamide antibiotic. It binds to the 50S ribosomal subunit and inhibits the protein synthesis. So now to see which are all the antibiotics which can be safely given during pregnancy and to be avoided during pregnancy. So the tetracyclines, contraindicated because of the discoloration of the tooth and inhibition of the bone growth. Aminoglycosides, again gentamicin, especially to be avoided during the first trimester because of risk of ototoxicity, nephrotoxicity. But in certain circumstances when there is a severe sepsis where it is not sensitive to other antibiotics, we can consider giving it. Fluoroquinolones to be avoided, contraindicated because of the bone, the tendon rupture as well as cartilage damage. Sulfonamides to be avoided during first trimester, third trimester. Trimethoprim, another antibiotic where antifolate and also the risk of neural tube defects, so it should be avoided during the early first trimester. Nitrofurantoin to be avoided in the third trimester because of the risk of having acute hemolytic disease of the newborn. Metronidazole, if possible, try to avoid in the first trimester, but can be safely given during the second and third trimester. Macrolides also can be safely, with caution, to be given during the pregnancy. Now moving on to the next group of drugs, which is the antihypertensives, which is also very important, especially in the pregnancy management. And these are the drugs which helps to reduce the maternal mortality rate and improve the perinatal outcome. So antihypertensive drugs can be broadly classified again depending upon the mechanism of action. So first is the beta blockers, and labetalol is a first line antihypertensive to be used for the management of hypertensive disorders in pregnancy. So labetalol oral preparations and IV preparations are available. So that basically acts by reducing. So labetalol is a non-selective alpha and beta blocker. It acts by reducing the cardiac output and heart rate. The next group of drugs is a calcium channel blockers. They are mainly including the nifedipine. So that is the second line of antihypertensive for hypertensive disorder of pregnancy. They act by reducing the systemic vascular resistance and cause vasodilation. So the nifedipine, they are basically acts against a voltage gated calcium channel influx. The third group is basically the drugs which are mainly hydrolysine. So before that, we can consider using alpha-methyl-dopa also. So first is labetalol, second is nifedipine, and third is alpha-methyl-dopa. Alpha-methyl-dopa is centrally acting alpha-2 agonist drug, but it has to be avoided during postpartum because of the risk of postpartum depression. So within 2 days of giving birth, the alpha-methyl-dopa, if the woman is on, has to be converted to other antihypertensives. The other antihypertensive drugs like diuretics, ACE inhibitors are better to be avoided during pregnancy. Diuresis because of the risk of renal insufficiency in the baby. Furosemide is the one example of a loop diuretic where it is indicated in giving when there is a fluid overload condition, like in case of acute pulmonary edema. And other antihypertensives which are to be avoided during pregnancy but can be safely during the postpartum period are the ACE inhibitors or ARBs, which blocks the renin-angiotensin-aldosterone system. While the ACE inhibitor enalapril is considered as one of the first-line antihypertensive drug for high blood pressure in the postpartum period. So the main purpose of giving antihypertensives is to reduce the risk of acute intracerebral events like stroke, intracranial hemorrhage, which has the potential to cause maternal mortality. So it is indicated when the blood pressure is more than 140 by 90 millimeters mercury in case of an OPD management, but in case of a hypertensive crisis or uncontrolled blood pressure, if it is more than 160 by 110 millimeters of mercury, there is still a very high risk of having a stroke. So we have to give the intravenous preparations or the sublingual preparations, whichever is readily available, in order to reduce the blood pressure. So as I've mentioned, according to the NICE guidelines, the first line antihypertensive is labetalol if the blood pressure is persistent more than 140 by 90 millimeters of mercury, and it is a non-selective alpha and beta blocker. It reduces the cardiac output and heart rate. The side effect, if given in high dose and for a long period starting from early pregnancy, there is a risk of fetal growth restriction, bradycardia, as well as neonatal hypoglycemia, which are rare. We usually start with 100 to 200 milligram twice daily, and maximum of around 2400 milligrams per day can be given. The next drug is nifedipine. Second line, it has got a tocolytic action. It is a first line tocolytic drug as per the NICE guidelines in pregnancy. Usually we start with 10 to 20 milligram once daily, twice daily, and maximum dose of 120 milligrams per day. Sustained release preparation is used, and sublingual preparation is not used nowadays because of the risk of acute fall in blood pressure and risk of IUFT. The calcium channel blockers are basically dihydropyridine groups, and they inhibit the calcium influx through the voltage gated channels. The side effects includes reflex tachycardia, headache, flushing, peripheral edema. So if the woman is already having headache, then usually we tend to avoid nifedipine. Another important thing is because the labetalol has got a beta blocker effect, it can cause bronchoconstriction, so it has to be avoided for asthmatics. So in case of asthmatics, then the first choice of antihypertensive is nifedipine and not labetalol. Then third choice is methyl-dopa. Sometimes even with two antihypertensives, the blood pressure is not getting controlled. So then we can add the third antihypertensive, which is a methyl-dopa. It is a centrally acting alpha-2 agonist, metabolized to alpha-methyl noradrenaline, which is an active metabolite. As it acts as a postsynaptic alpha-2 agonist, reduces the central sympathetic outflow. The side effects are postpartum depression, reduced CTG variability, depressed mood, rebound hypertension, autoimmune hemolytic anemia, hepatitis-like reaction. And if in spite of three antihypertensives, or if any of these antihypertensive is not suitable, then another antihypertensive oral preparation which we can consider is hydrolysine oral dosage. It is a arteriolar dilator and reduces the blood pressure. So the beta blockers, labetalol, which is safely used as a first line, and calcium channel blocker nifedipine, it is used as a second line, and centrally acting alpha-2 agonist methyl-dopa, it is used as a third line. Hydrolysine, if required, can be used add-on. ACE inhibitors, ARBs, diuretics, and other alpha blockers, all these drugs are usually avoided. But alpha blockers like prazosin, doxazosin can be considered if the blood pressure is not getting controlled with all other antihypertensives. With caution. The dosage is beta blocker, maximum dose of 2400 milligrams per day. Calcium channel blocker is maximum dose of 120 milligrams per day. And alpha methyl dopa usually given as 250 milligram 2 to 3 times daily for up to 2 grams per day. Hydrolysine is given as a dose of 25 milligram oral or IV preparation, and that can be given twice daily or thrice daily. So in case of preeclampsia with severe features, that is if the blood pressure is more than or equal to 160 by 110 millimeters of mercury, if there is an eclampsia or hypertensive crisis or uncontrolled blood pressure, in order to reduce the risk of acute cerebral events, we have to consider the intravenous preparation where there is an immediate onset of action. The first line again is a labetalol, started with a dose of 10 to 20 milligram and repeated every 20 minutes, and maximum dose which can be given in a day is 300 milligram. The hydrolysine is the second dose. It is a direct arteriolar vasodilator, started with a dose of 5 to 20 milligram and check the blood pressure every 20 minutes. If still high, we can give, and if it is still not responding, switch to the other antihypertensive. Nifedipine, sustained oral release, can be given. Here, oral tablet preparation is given in case of hypertensive crisis, and 10 to 20 milligram orally every 30 minutes can be given. Another important drug for the management of the hypertension in pregnancy, especially severe hypertension, is the magnesium sulfate. It is not an antihypertensive drug, it has got an anticonvulsant action. So there is always a doubt in some of the recalls that if a woman is coming with impending eclampsia, with the blood pressure more than 160 by 110, with headache and vomiting, and with hyperreflexia, then what is the first drug which we have to give? If they have mentioned that it is a very high blood pressure, which is an uncontrolled blood pressure, then always the first thing we choose is the IV labetalol. And then the next time which you have to choose is the magnesium sulfate. But if they have mentioned, like if it is a severe preeclampsia or an impending eclampsia, whatever, with an increased risk of seizures while the blood pressure is not in the range of hypertensive crisis, then you have to think of giving magnesium sulfate. But the first thing we have to remember is you have to reduce the risk of stroke and then the eclampsia. So magnesium sulfate, the mechanism of action is a membrane stabilizer. It has got rapid onset of action. So it started with a dosage of 4 grams loading dose, followed by 1 gram per hour over 24 hours after the delivery or after the last seizure, whichever is later. It is used in eclampsia, severe preeclampsia, or in case of impending eclampsia. Also, it is used for the fetal neuroprotection. Side effects are respiratory depression, CNS depression, cardiac arrest, hyperreflexia. So while we are giving the medication, we have to monitor the woman with the urine output, respiratory rate, as well as the deep tendon reflexes. Because it is a drug with narrow therapeutic index, routine serum magnesium level monitoring is not done if the woman has got normal renal function. But if there is a renal impairment, give the standard loading dose of 4 grams IV, followed by half the dose of maintenance, which is 0.5 grams per hour. And you have to do every 4th hourly serum magnesium level monitoring also to look out for magnesium toxicity. If there is a toxicity, then antidote to be given is 10% 10 ml of calcium gluconate. And it has been shown from the MACPI trial that the magnesium sulfate can halve the risk of eclampsia and reduce the maternal mortality rate as well. The next group of drugs is the NSAIDs, non-steroidal anti-inflammatory drugs. They can be non-selective and selective. The non-selective are the main group of drugs, which includes the aspirin, which has got an effect not only the anti-inflammatory, it has got an antiplatelet action also. And also the other groups like mefenamic acid, ibuprofen, naproxen, and all those things. The selective COX-2 inhibitors are the celecoxib as well as etoricoxib. They are very specific for COX-2. What is COX? It is a cyclooxygenase enzyme in the pathway of the synthesis of prostaglandins. Then the others, which are paracetamol, it has got an analgesic action, an antipyretic action, and also anti-inflammatory action. It is not really an NSAID, but it has got this effects. So the aspirin, it is a non-selective NSAID, but more selective for COX-1. and it is started from a low dose of 75 to 150 milligram. I'll be discussing about the indications where you start the aspirin low dose for prevention of preeclampsia. Non-selective other COX inhibitors are ibuprofen and naproxen diclofenac. These are all having a side effect, mainly the GI upset, and long-term high dose usage can result in the peptic ulcer, gastritis, and can also cause enzyme elevation of the liver and renal impairment. Celecoxib is a selective COX-2 inhibitor, and paracetamol is not an NSAID, but it is considered to be safe for administration in all the trimesters. What about the aspirin and its difference from ibuprofen? This was one of the recall. Aspirin irreversibly inhibits both COX-1 and COX-2, but more so inhibits COX-1 than COX-2. The main mechanism of action of ibuprofen is a non-selective COX-1, COX-2 inhibition and reversible inhibition of the cyclooxygen enzymes, which is COX-1, COX-2. So aspirin, more of COX-1 than COX-2, irreversible. Ibuprofen, both equal effect on COX-1, COX-2, and it is reversible. So what are the indications of giving low dose aspirin? So it is given mainly for the prevention of preeclampsia starting from 12 weeks of gestation with a low dose of 75 to 150 milligram, usually preferred at bedtime because of the risk of gastric upset. It is indicated when there is one major risk factor or more than one moderate risk factors. What are the major risk factors? Hypertensive disorders in a previous pregnancy, chronic kidney disease, type 1 or type 2 diabetes mellitus, chronic hypertension, or any autoimmune disorders like SLE, Sjogren's syndrome, rheumatoid arthritis, or antiphospholipid syndrome. What are the moderate risk factors? Nulliparity, age more than 40 years, pregnancy interval of more than 10 years, BMI of 35 or more, family history of preeclampsia, and multiple pregnancy. So now moving on to the another important thing about the NSAIDs, they are to be avoided during the third trimester because especially ibuprofen and naproxen, not aspirin. Aspirin can be continued in the third trimester, but mainly for the ibuprofen and also the other NSAIDs because of the risk of having premature closure of ductus arteriosus, oligoamnios, especially when administered in the third trimester. So it has to be avoided in the third trimester of pregnancy. The last group of the drugs for today's discussion is the anticoagulant drugs. The anticoagulants can be heparin group of drugs, warfarin, which are the coumarin derivatives, which are vitamin K antagonists, as well as a direct oral anticoagulants. So heparin group of drugs includes both unfractionated heparin as well as low molecular weight heparin. So the unfractionated heparin, it has got easy reversibility, especially towards the end of the pregnancy, and also because it has got a short half-life compared to the low molecular weight heparin, but increased risk of having hemorrhage and long-term usage can cause osteoporosis, as well as there is a risk of having HIT, which is heparin-induced thrombocytopenia, and there is a problem of having needing to take injections more than once daily. While low molecular weight heparin has got a longer half-life compared to the unfractionated heparin, but the reversibility is difficult, and also there is a ease of needing only in a prophylactic dose, only once daily injection is required. Another important difference of is the monitoring. So unfractionated heparin is monitored by APTT levels, while low molecular weight heparin is not monitored during pregnancy unless there are any specific indications like severe renal impairment. In that case, anti-10A level is used. Now coming to the next group of drugs, which is a warfarin, which are vitamin K antagonists. They act against the clotting factors, which are the vitamin K dependent clotting factors 2, 7, 9 and 10. They are coumarin derivatives. And the third group is a direct oral anticoagulants, which includes mainly the factor 10A inhibitors, rivaroxaban, apixaban. These has been used as I have asked several times in the recalls what is the mechanism of action of apixaban, rivaroxaban, warfarin, and the direct thrombin inhibitors are the dabigatran. So apixaban and rivaroxaban, they are factor 10A inhibitors. Dabigatran is a direct thrombin inhibitor. So looking into more about the mechanism of action, we actually have to look through the coagulation cascade, both extrinsic pathway, intrinsic pathway, and common coagulation cascade. If you look into it, as I've mentioned, for heparin, both unfractionated low molecular weight heparin, it activates at antithrombin 3 and inhibits factor 10A and 2A. And the unfractionated heparin, it has got equal inhibition of 10A and 2A, while low molecular weight heparin acts mainly and inhibits more of 10A. So that is why anti-10A level is used for its monitoring in severe renal impairment. Warfarin group of drugs, they act by inhibiting the synthesis of vitamin D dependent clotting factors 2, 7, 9, 10. Direct thrombin inhibitors like dabigatran, they inhibit factor 2A. And the other group, which is anti-10 inhibitors, are rivaroxaban and apixaban. They are other group of direct oral anticoagulants, which are not usually used during pregnancy. So that is the same thing which we have discussed. So unfractured heparin, both factor 2A, which is a thrombin, and 10A. Low molecular weight heparin, mainly 10A. Warfarin, 2, 7, 9, 10. Rivaroxaban, apixaban, factor 10A, and dabigatran, factor 2A. Coming to about the dosage. So dosage differs for prophylactic dosage as well as the therapeutic dosage. In case of prophylactic dosage, the standard dose for a standard weight is, that is if it is between 50 to 90 kg, is 40 milligram once daily. And that is for enoxaparin. And if it is less than 50 kg, it is 20 milligram once daily. And if it is 90 to 130 kg, then 40 milligram twice daily. And 130 to 170 kg, it is 60 milligram twice daily. And more than 170 kg, it is 0.5 milligram per kg twice daily. While in case of therapeutic dose of low molecular weight heparin and unfractionated heparin, if it is less than 50 kg or 50 to 90 kg or 90 to 130 kg or 130 to 70 kg, it is usually 1 milligram per kg body weight twice daily subcutaneously. And if it is more than 170 kg, then maybe 1.5 milligram per kg body weight once daily can also be given. So low molecular weight heparin, if it is a prophylactic dose, it has to be stopped at least 12 hours before the planned vaginal delivery or onset of labor. Can be started as early as 6 hours after vaginal delivery and after around 6 to 12 hours after a cesarean section. While if it is a therapeutic dose, it has to be stopped at least 24 hours prior to the onset of labor or planned vaginal delivery. Can be started 24 hours after the postpartum hemostasis has been achieved. Unfractionated heparin, if it is a prophylactic dose, it need to be stopped at least 6 hours prior to the delivery and can be started 6 hours postpartum. And if it is a therapeutic dose, to be stopped at least 6 to 12 hours before the procedure and can be restarted 12 hours after the procedure, ensuring the APTT is maintained within the normal range. So this will give you a better idea about the mechanism of action, at what levels each anticoagulant is acting on. Warfarin. Warfarin is important because of the risk of teratogenicity, and the risk of teratogenicity is maximum during the critical period of organogenesis, that is between 6 to 12 weeks of gestation. So warfarin is a anticoagulant which has to be given in certain cases during pregnancy and cannot be replaced by heparin, especially in case like metallic prosthetic heart valves, where in spite of heparin, sometimes there is an increased risk of high thromboembolic risk is there. In case of such conditions, usually what we do is we give warfarin up to 6 weeks of gestation, and 6 to 12 weeks of gestation we switch over to the heparin, low molecular weight heparin or unfractionated heparin. Again, from 12 to 36 weeks gestation, back to warfarin. From 36 weeks of gestation, again from warfarin switch to heparin because of the risk of having intracranial hemorrhage of the baby in case on warfarin they go for a sudden onset of labor and vaginal delivery. Because the warfarin at higher dosages, especially more than 5 milligrams per day and on a long term of more than 3 weeks, there is an increased risk of having fetal warfarin syndrome, that is warfarin embryopathy, which has got 5% risk is there, also known as Conradi-Henneman syndrome, where there is multiple craniofacial skeletal abnormalities. And compared to the background risk of general population, the additional teratogenesis risk of the warfarin is 2%. So it is dose dependent, especially if the dose is more than 5 milligrams per day, there is increased risk of having warfarin embryopathy, consisting of chondrodysplasia punctatia, midfacial hyperplasia, pectus carinatum, stippled epiphysis, scoliosis, CHD, ventriculomegaly, as well as laryngomalacia. Warfarin is monitored with PTINR levels. So that's a recap of the important topics or antibiotics, antihypertensives, NSAIDs, and also anticoagulants. If you have any doubts, please put in your comment box. Thank you. All the best for your Part 1 MRCOG examination.